Great, thank you very much, and thanks very much for the invitation. It's a terrific course, I know, and hopefully next time we'll be all in person, as everybody has said all along. So I was asked to speak a little bit about the context of treatment and in the context of cancer predisposition, and it's a very intriguing area. There's a lot of interest in this, and I'm going to basically go through 4 contextual syndromes to articulate some of the lessons that we may be able to learn in applying germline cancer genetics to potential therapies. So, and then a little summary at the end. So this just takes one example of medulloblastoma to put into context, and this is a paper that was published a few years back now, where we, with a large group from around the world, were looking at the presence of germline mutations in children with medulloblastoma, and found, first of all, that about 13% of children did carry a variant in one or another gene. And many of these, as you can see here, it's a little small, are in the DNA damage repair pathway, BRCA, PALB, PAT, SUFU, P53, and so on. But what's important to recognize here is, in these Kaplan-Meier curves, is that the underlying genetic alteration definitely had a impact on outcome. And so, for example, patients who had a germline P53 mutation had the worst outcome by far, whether it be overall survival or event-free survival, compared to, for example, patients who carried a BRCA2 variant. So this lesson is very interesting, and I think we can apply that, as you'll see, going forward. So the next few slides were shared with me by Brigitte Wiedemann, who's at the NIH and is an absolutely fantastic, she leads the pediatric branch there and has a fantastic long-term interest in neurofibromatosis, among other things. And just to remind again, this group doesn't need reminding, it's a common single gene disorder involving RAS pathway activation through mutations in the NF1 gene. A variety of both benign and malignant tumors can develop, and virtually all organs can be affected. And what's interesting and important to recognize is that if you look at the different manifestations of the disease, there's actually a correlation to a certain degree with the type of variation at a genetic level that occurs. So example, biallelic loss of NF1, which is pretty much in everybody, without anything else, you do get the cutaneous manifestations. Very frequently, you will end up with these plexiform neurofibromas when you have an additional somatic loss of CDKN2A or 2B, and then this becomes malignantly transformed when one loses PRC2 or P53 or a variety of other genes. So there's this accumulation of events, somatic events, that are required for full malignant transformation. So how can you take this sort of information and develop it further? And so a number of years ago, the NIH developed a study using MEK inhibitors, in this particular case, one of the earlier ones, tepifernib, in a crossover study to really try to just demonstrate whether there was any benefit, therapeutic benefit, in the context of plexiform neurofibroma. And when one looks at the results of this, in fact, there really wasn't any particular benefit over placebo, as you can see here in the black curve, against various of these sort of first generation agents. And in fact, the numbers only showed about 2 out of 175 had a partial response. So as more drugs become available, one starts to see that there are, one starts to see responses. And so in this context, we see that using these agents, you can get in this waterfall plot, we see a percent change in tumor volume ranging down to about 50%. So a very significant clinical response, which doesn't appear necessarily to be dose dependent, although for this particular study, it was a phase 1 study, was really just trying to achieve a maximum tolerated dose. But what is pretty spectacular, and this was published in the New England Journal, was that the use of selumetinib really could demonstrate in some patients very striking and significant responses. These are usually measured over many, many months, if not years, but with relatively limited toxicity. And so as this study was developed further with more patients being enrolled and looking at morbidities, comorbidities, not just how the tumor was responding, but many of the side effects of having the disease and the tumor, one can see some fairly impressive responses, partial and confirmed partial responses, with a relatively low progressive disease, very different than the original studies that were done. And this is just another example of another patient who's had, you can see here, quite a striking response, though admittedly after many, many cycles of therapy. Sorry about that. So when this trial is basically just looking at each of these lines represents an individual patient. And again, you can see that based on the natural history of the disease, there's basically progression in many patients, or sort of stability, but with pretty high percent progression of the size of the tumor, whereas the vast majority of patients who are on study had developed either some degree of remission, significant remission, or in the worst case scenario, stable disease. And one sees here a very dramatic advance in survival. And so this therapy is now really considered a standard of care for these patients. Okay. Now, as time has gone on, this is, again, that same curve that I showed you previously, but now with selumetinib showing a much better response, up to 80% overall compared to the historical controls. Now, of course, it's not perfect by any stretch of the imagination, but also it has not really been shown to be effective in the context of malignantly transformed malignant peripheral nerve sheath tumors that are transformed to sarcoma. So other agents are now in trial, and some of these are being used in the context of combination studies. Now, one of the points that I bring out here is in the context of any new drugs, particularly where the germline event is going to lead to a pediatric tumor, or a tumor in the context of children, formulation of the drug is critically important, because many of these novel agents and newer agents are actually oral. Clearly, children who are just a year or two old are not able to handle a large capsule or tablet. And so a lot of the work with industry is to ensure that they continue to remember to try to develop these as oral solutions. So if we take NF as an example, there are other disorders, and this one in particular, which we'll talk about for the next few slides, is in the context of CMMRD, or constitutional mismatch repair deficiency, and Elitu Uri-Tabori, who many of you will know or know of. And actually, just this morning, Uri gave a talk to our group, to our division, with a lot of international people tuning in, on this spectacular story of from diagnostics to novel therapies in the context of CMMRD. And I would actually encourage any of you to reach out to him, to invite him to give a talk at your institutions. Absolutely brilliant work. I'm just going to summarize it in a few slides, and to remind people that CMMRD is similar but very different than Lynch syndrome, and is associated with, it's a two-hit model based on the Knudsen hypothesis in the mismatch repair pathway with patients who have a high risk of brain tumors, particularly malignant high-grade gliomas or glioblastoma, colon cancer, and to a lesser degree, but still present, lymphoma and leukemia. The pathway that is involved entails a germline variation or germline mutation in one of the key mismatch repair genes, MLH1, MSH2, PMS2, or MSH6, which then you get an accumulation of inability to repair, which is exaggerated by somatic variation or variants in either POLE or POLD, the polymerase chain pathway. And so this leads to this very aggressive, very early onset and highly penetrant phenotype, which is articulated here. As I mentioned, brain tumors, GI cancers, and hematologic malignancies account for the bulk of the tumors. But in fact, many of these patients actually present or have as secondary tumors, malignant tumors of almost every other organ has been involved. And this paper was published just last year through the International CMMRD Consortium. Now, if we go back a few years when Uri was just really studying this, and he teamed up with a brilliant bioinformatics computational biologist, Adam Schlein, in our institution, and looked initially at, in a collaboration with Foundation Medicine, at mutation burden. And what was recognized is that the tumor mutation burden, which you heard a little bit about in the last talk, was extraordinarily high in patients who had biallelic mismatch repair and brain tumors. And here you can see the mutation burden well over 100 to 1,000 mutations per megabase, which is well above any other pediatric malignancy, and frankly, well above almost all other adult malignancies, colon cancer kind of, and sort of fits in that model, as well as melanoma to a certain degree. And what, of course, was interesting is all these patients in the adult world were at the time under various forms of immune checkpoint inhibition trial, immunotherapy, where these tumors demonstrate a high PDL or express PDL1 and have a high tumor mutation burden and high antigen presentation, suggesting they are good responders. So with that information in hand, Eric Buffet, who just recently retired from our institution as the head of the neuro-oncology program, together with Uri and others, took a very bold step, which is to treat two children. These happened to be siblings who were both palliative at the time that they were referred, with recurrent glioblastoma multiforme after multiple therapies. And they were treated with nivolumab, so at that point, single agent immunocheckpoint inhibitors, and you can see a dramatic resolution of the primary tumor in each of these children. Now, ultimately, the tumors did recur, but we now actually have patients who are on this therapy who are now several years post-therapy, having been treated for high-grade glioblastoma, and that in and of itself is fairly remarkable. Now, another patient who happened to be referred from Australia, a 13-year-old with metastatic colorectal cancer, as well as a GBM, was also treated. Here you can see the metastases and bony metastases in the wrist and the proximal femur. And in fact, after only 3.5 months of therapy, you can see this dramatic reduction. Now, interestingly enough, he had a very large colorectal cancer, which was metastatic. Because of this, no resection was done of this tumor, no primary resection, but the therapy alone, you can see a dramatic resolution of the primary tumor. So it's clear that at least in some of these patients, they can get very dramatic responses. And a paper that was just published last month, led by Anirban Das, who's a fellow in our program and working with the international consortium, it demonstrated that the use of immune checkpoint inhibition in the context of these germline mutation carriers of the biallelic mismatch repair, do show a significant response to therapy. With in blue here, these are patients who had glioblastoma, and you can see about a 50% overall survival. Patients with GI cancers, colorectal cancer, have about an 80% overall survival. Patients with the leukemia lymphoma still do not respond well at all to therapy, and clearly more needs to be done. So there are new trials now using combinations of immunotherapy with MEK inhibitors and other targeted agents to try to refine the approach to treatment in this otherwise previously devastating disease. Of course, much of this work, as you've heard through the course today, are related to diseases that are relatively rare. And so really it's fair to say that Uri and his team would not have been able to do this without really developing an international consortium. And this applies to pretty well all the other hereditary cancer programs that we study, that we talk about, and that we care for patients. So then the third model will be Li-Fraumeni syndrome, and it's a bit of a different story from the first two. So just to remind people, you've seen this contextually, Li-Fraumeni syndrome is a multi-generational cancers with high penetrance, and patients develop multiple tumors very often at very early ages of onset. But in addition to that, we also see families like this, where essentially there's no family history whatsoever, but a patient presents with some harbinger cancers, in this case, hypodiploid ALL, goes on to develop multiple cancers. And eventually, this was a patient of mine who passed away after about 14 years with having had 6 different malignancies. So the heterogeneity of the disease is quite striking, but the key feature is that the cancers do occur quite commonly at very early ages of onset. And we know, as we mentioned, that p53 is the gene that is primarily associated with the clinical spectrum of disease. And just to remind people, p53 is the guardian of the genome that activates downstream targets when functioning properly to induce apoptosis, growth arrest, senescence, and DNA repair. So a number of years ago, we had developed this surveillance protocol for early tumor detection, and a number of institutions around centers around the world use this or have modified it a bit. And overall, the survival for patients on therapy, on surveillance is much better than for patients who are not on surveillance. Now, doing the surveillance leads to some interesting findings. So this is a young girl who is now 15 years old, and I've been following her essentially since birth, when she was found to carry a mutation based on a strong family history. A whole body MRI, which was done about 1.5 years ago now, yes, 1.5 years ago, 2 years ago, was essentially unremarkable and normal. And then she presented, however, to her next annual MRI with very distinctive bone marrow infiltrative disease here. And about just a few weeks before, she had routine blood work, which was entirely normal. And it turned out, not unexpectedly, that she had actually a diagnosis of pre-B ALL, masked hypodiploid, which is typical in the context of germline mutations. But using standard therapy, she at day 28 had not achieved a minimal residual disease of 0. She was still had 5% minimal residual disease. So after much discussion to try to avoid radiation therapy in her, we elected to use CAR T-cell therapy. And she has actually remained in MRD negative at about 50 weeks since she started that therapy. So we don't know in the context of her where this is going to lead, but we've actually also now started a study, sort of retrospective, with as many colleagues around the world as we can find in both the leukemia and the Li-Fraumeni world, to determine whether who's using CAR T and other gene therapy types of approaches or immunotherapy approaches in the context of leukemia in Li-Fraumeni syndrome, and what the outcomes are. Because if it turns out that this is a viable approach, then it eliminates a lot of the toxicities that we associate with cancer therapies that are typically given. So another study that was done, and it's actually just been accepted a couple of days ago, was completed by an MD PhD student in our group, where Nick Light, analyzed tumors from Li-Fraumeni patients to sort of explore, were there targets there? Was there a sort of signature, if you will, that could be helpful in identifying potential therapeutic options for these patients that would be unique to Li-Fraumeni syndrome and perhaps distinct from other types of somatic or sporadic cancers. So in doing this sequencing effort, and this I know is a fairly complicated slide, but really just on the top are sort of the parameters of the clinical parameters, the tumor types, age of onset, and so on. But I'm going to focus for the purpose of this in this area. So what we were looking at are tumor signatures, and we've heard a little bit about this already, this concept that genetic variation or genetic mutations across the genome often reflect exogenous or external influences on DNA that can be reflected in these classic signatures. And so when we looked at the signatures of these tumors, it was found two things in particular. One is that signature 3, which is the BRCA in this signature, BRCA, is found in almost all of the tumors that were sequenced. And the second, though, related to this particular talk, is the concept of the molecular scar. And it turns out that in these two patients, they had a molecular signature that is associated with cisplatinum or platinum exposure. And why was this of particular interest? Well, it turns out that both these tumors were secondary malignancies that in patients who had previously, years before, received platinum therapy for another tumor. And what it indicates is that the therapeutic scar from that prior therapy is still present years later, and in fact could actually be responsible for induction of malignancy going forward. And so we do know, or we anticipate, that individuals that carry germline mutations are at exceedingly high risk developing treatment-related malignancies. But this is really one of the first sort of examples, if you will, demonstrating that in real life. The second important point from this, however, is as I mentioned, we were looking for sort of a unique signature to Li-Fraumeni syndrome. In fact, we don't really see that, but what we do see is when you look at individual patients across the board here, almost all of them do have at least one or more other secondary acute sporadic event in one or more of the DNA damage repair pathway genes. And this therefore becomes important because it suggests, in fact, that we may be able to use targeted therapies to these downstream targets, not so much P53, but if we can anticipate that we're going to see alterations in other druggable targets like BRCA here or CHEK2, for example, then there may be therapeutic options that are distinct from chemotherapy or radiation. The holy grail, if you will, to be able to get there would be to actually have targeted P53 targeted therapies. And until very recently, these have been very hard to come by. But there are two that I'll just mention briefly. One that has been developed at the Weizmann Institute in Israel by Varda Rotter and Moshe Oren and their team is a P53 conformational activating peptide, and there's a whole series of them. This is one that is particularly one that they published and has had a lot of attention, which stabilizes mutant P53 and induces, as you can see here, apoptosis, as well as inducing downstream apoptotic targets. And this particular peptide binds to the P53 molecule, and in ways that are not entirely clear is able to stabilize it, and so it starts behaving more as a wild type. And in fact, when you do this in vivo studies, in this case in mice with xenografts implanted with tumors that are P53 mutant, you can see that there's a striking effect in eliminating the tumors in patients, or mice rather, that are treated with this. Now, these are not in p53 knock-in mice. These are not in mice with germline mutations, but it does show that the agent is effective in the context of p53. And a second agent, which has been in clinical trial for a little while in different contexts in the adult world, is APR-246, developed out of the Karolinska Institute and Aprea, the company that spun off from that. And this is another agent that also converts the mutant to wild type conformation by stabilizing the mutant conformation. And it binds to the to cysteine residues in the p53 core domain. And in so doing, it is able to stabilize the protein. And a recent study demonstrated that in the context of myelodysplastic syndrome used together with azacitidine, there appeared to be an improved clinical response rate in individuals whose tumors had mutant p53, and the mutant p53 was cleared essentially from those cells with treatment with APR plus azacitidine. Now, a more recent phase 3 study suggests that it may not be any more beneficial than the azacitidine alone. And so clearly more studies are underway and as yet have not been explored in the context of germline mutations, but that would be the next step clearly to do that. So summarizing this part, then, it would suggest that we actually, what I didn't show you is loss of heterozygosity is virtually ubiquitous in Li-Fraumeni syndrome tumors, and also therefore goes to the other question is, could we ever think of blocking or inhibiting the loss of heterozygosity event in the context of LFS? And if there were molecular ways to do that, then that might be a way to literally prevent the malignant transformation of tumors and just leave them in their sort of more benign form. And then I'll just finish off then with some comments that a lot of you've heard, of course, there are a lot of precision oncology programs around the world. And one thing that's become quite clear and apparent, and work that's led by Christian Kratz in trying to pull a lot of this data together, Christian's in Hanover, is what is the rate and type and frequency of germline variants in the DNA damage repair genes. And in fact, about 12% of patients in our cohort in our precision oncology program, but actually it's about 17% have pathogenic germline variants, and about 5% are found in one or other of these DNA damage repair pathway genes. And this is important because many of these actually do have drugs available to target them. And so PALP2, CHEK2, BRCA2 are key targets. And so one can start imagining using these drugs in the context of pediatric medicine, though those trials still need to be developed. One that is in very recently opened out of St. Jude is a phase 1 study using olaparib and talazoparib, both in the context of patients with deleterious alterations in the homologous DNA repair genes, but also those that are found in the germline. And so over time, as this study evolves, and it's a multi-institutional study, that we'll be able to detect whether these drugs are effective. So looking to the forward, I think as we better understand the potential role for therapeutics in the context of germline variants, it will be important that we continue to do genome-based sequencing of all children with cancer at diagnosis as much as possible and get a better sense of what the events are that are occurring. That more germline genetic landscape studies need to be done to inform more tumor-specific targeting and other syndromes and other disorders, as well as the opposite, which is treatment-related toxicity and what effects treatment are having at a genetic level. This will lead to much more rational design of these novel targeted or immunotherapy models, as we've seen in sort of the example of CMMRD, and presumably may be applied to others as well. We see even the context of p53 mutations, some patients have a very high tumor mutation burden, suggesting they would be good candidates for immunotherapy. We and everybody is starting to explore the epigenome and especially the microbiome in the context of pediatric cancers as well as in adult. And doing this in the context of hereditary cancer will be important because one might anticipate that the microbiome may be different in these individuals. And then finally, of course, using circulating tumor DNA or exosomes or other forms of early detection and matching that against therapy will be important so that as we invoke these new therapies, we can actually have a better idea of what their response is at a tumor level. So I just again like to thank everybody, both in our labs at SickKids and some in the recent past, many collaborators nationally and internationally, lots of funding coming from various sources, fortunately, and of course many of the families, both the Li-Fraumeni families and those and the others as well, who really make all this work happen. So happy to answer any questions. Thanks.
Thank you very much, David. Always very up to date, so I learn a lot every time. Thank you. So Jürgen has the question, and please just go ahead and ask questions.
Hello, David.
Hey, Jürgen.
Hi. Perfect presentation. You are running through all the possible therapies and treatment options we have. One question was one on your last slide on point 2.2. The effect of this novel treatments we have, like for checkpoint inhibitors or CAR-T cell treatments. Do you know the side effects of survivors? Are there enough experience at the moment what children will have in future on comorbidities?
So that's such an important question. Thank you for asking. I think the simple answer is probably no. And the reason for that, of course, is that these agents, immunotherapy, or even many of the targeted agents are only relatively new, right? And so whether that be in children with sporadic cancer, or for sure in children with germline events where the numbers are very, very much smaller. So this is something that I think is absolutely going to need to be followed over the years to come, because we always are talking about, molecular targeted therapies. That's the way to go. Once we find the target, we have 50 years worth of long-term data on chemotherapy and radiation. We have maybe 5 years on long-term data for most of these other drugs. So I don't think we know the answer to that. Really important to find out, though. Yeah.
Thank you.
Thank you very much. Any further questions, clarifications? Please go ahead, and maybe very implicated for the daily work for us.
We have 2 questions in the chat.
Yeah. So one of them is really interesting. Yeah. Are there any data about the duration of targeted therapy in the context? So in the context of immunity, might be the other thing. I can't pronounce out these drugs. In NF1, is they are used long term, and we do know that we use them sometimes. That you use them for a long time, and if you're starting to develop some toxicity, then give the patient a little bit of a holiday from the drug, take them off it for a period of weeks, and then you can start back on. And Brigitte has been amazing. She showed some data where you can start and stop and sort of reduce the toxicity in that way to a certain degree. In terms of the nivolumab, so the biggest problem with the immunotherapies is that you can get these flare and a really quite striking flare phenomenon where it appears sort of a pseudo progression of the tumor, which can be quite traumatic, and the kids and adults can get quite sick from that, particularly when it affects lungs or brain. And so in those scenarios, there's that balance between pushing ahead, knowing that if you get past that hump, then you can get long-term response versus needing to stop simply because the patient is too sick. And so it's that balance. But there are definitely patients that we've been following here, that Uri and his team for a long period of time, many months, if not years, who are on ongoing therapy. But often they do start to not fail therapy, but the toxicities start to accumulate and you have to stop. Yeah, it's interesting about the patient that you, Yasmin, put up here with CAR-T, who developed hypogammaglobulinemia. Yeah, so again, CAR-T, of course, does have its toxicities that I don't do any of the CAR-T therapy. I'm not a leukemia doc, so, but absolutely in the field, it is one of the things that one has to be aware of.
But if I can add, we saw also hypogammaglobulinemia after BMT. So it is hard maybe to distinguish, is it the effect of CAR T cell or failed BMT?
Yeah, right, yeah.
Yeah.
And I have a question, if I may. Child with retrobulbar plexiform neurofibroma. Unfortunately, selumetinib was not available in our country, so we started with trametinib and experienced pretty high skin toxicity. And we were in favor of not making a pause of the drug, but a decrease, and actually it helped. And my question to you is, if we make these breaks from therapy, does it maybe erase the resistance?
Yeah, I think the answer is probably yes. I think it's sort of probably still applies as a general oncologic principle, is even with other drugs, you know, our more conventional therapies, chemotherapy, we do, I mean, I think there's just historically lots of evidence that stopping and starting is not as effective as pressing forward where possible. But it still gets to the point, of course, is if the toxicities are not manageable, then one does have to slow down. I actually have a patient, Gert literally was going to do rounds soon, with a very rare angiosarcoma of the breast, which is a terrible disease and it's metastatic. And we know ultimately it's not curable, but you know, we are able to achieve excellent response and stability of disease with treatment. I mean, we've demonstrated it, but she gets really sick from it. And so, and every time you kind of hold back, things start to come back up again. So trying to find that fine line is so important. I think in the context of germline events, it will be interesting too, because most of these disorders are associated with multiple types of cancers, right? So what we really need to do are find more preventive agents that are can be started in patients early on before they've developed any cancer, and then try to run those through. And so in the context of Li-Fraumeni syndrome, metformin has been explored, and we're exploring it, other drugs as well. But really the bulk of these, there is, for the bulk of the hereditary cancers, there's really no preventive therapies that are, you know, out there, even in the adult world.
Thank you.
David, short question. What is your idea for these preventing drugs?
Well, I'm sorry, I didn't quite...
You mentioned the last two sentences that the best way is that preventing drugs that cancer cannot develop would be the best choice, what we can have. What is your idea, your personal idea to develop in this or to work in this way?
So, you know, I sort of alluded to it a little, and we've had discussions with, particularly in P53, but this should apply to many of the others, is if we understood the mechanism for loss of heterozygosity was, and then could develop drugs that actually target that molecular mechanism, so that the tumor retains one wild type allele, whether that be P53 or BRCA or TNF1 or whatever it is, then you should be able to prevent that malignant transformation. But like, so the basic fundamental science needs to be worked out. We don't really understand what causes LOH, but if we did, that would be an amazing target. So it's another number of years of research.